Welcome all of you. Welcome to our yet another episode of the last minute revision MCQs brought to you by Unacademy. I am your pharmacology educator, Dr. Arpit Agarwal, and I welcome you to this episode where we are going to discuss drugs for glaucoma. So this is our attempt before the NEET PG to revise the last minute most important MCQ in the latest pattern. So brief introduction about myself. I am your pharmacology educator, Dr. Arpit, MD in Pharmacology. I've been teaching pharmacology to students both in India and abroad for over 10 years now. And in all these years, I have successfully mentored more than 50,000 students preparing for pre-PG examination as well as the FMG, that is the MCI screening examination. If you are the first time visitor to the Let's Crack NEET PG YouTube channel, and if you have not downloaded the Unacademy app, then what are you waiting for? Please type Unacademy on the Play Store and download the Unacademy Learning app right away and see for yourself how the best educators from the country are going to help you crack NEET PG, crack FMG, crack INICT. Satyam SS has joined. Satyam, good evening. I hope you are doing well. Unacademy brings you the Plus subscription, the only subscription of its kind which gives you daily and unlimited live classes from the top educators in the country. The courses are structured to suit your requirements. We have separate batches for INICT, NEXT 2020-2022, FMG as well as the upcoming NEET. Along with that, you get the unlimited live tests and quizzes where you can evaluate your preparation, and obviously needless to say, unlimited access. Similarly, there is something called iconic subscription. As the name suggests, it is really iconic. It gives you best of the two learning platforms, that is the Unacademy as well as the Prep Ladder. So you'll get live classes with Unacademy and the recorded apps with the Prep Ladder along with the Question Bank 2.0. So iconic subscription is really iconic in itself. We have launched the INICT, upcoming INICT 24-day rapid revision batch on 7th of April. So this is going to cover 19 subject-wise tests followed by the discussion, 3 grand tests, rapid revision, and the top educators along with the PDF of the recorded sessions. You can also enroll into FMG test and analysis batch which has just started. It has 9 subject-wise tests followed by discussion, grand test, rapid revision of the high-yield topics, and the top educators will also provide their PDFs. So if you are the Plus subscriber, you get access to all these courses. These are just a few amongst the many batches which are available. Remember to use the code Dr. Arpit Agarwal. This code Dr. Arpit Agarwal, you can unlock free classes if you are the first time subscriber. And if you are willing to opt for the Plus or the iconic subscription, then this code would also help you in giving a 10% discount. So Plus subscription you can avail for short duration like 1 month or 3 months, or for longer term duration like 24 to 36 months. Depends on your level of MBBS stage right now. And iconic also can be availed for 12 to 36 months. The prices are very economical considering the package that you get. The live classes, the recorded apps, unlimited access, live tests, PDFs, everything you get in these subscriptions. This is the schedule of our ongoing Pharma Last Minute Revision MCQ. This is going on the Let's Crack NEET PG channel. So if you have not yet subscribed, I don't know what you are waiting for. Right now, hit the subscribe button so that you get the timely notification. As you can see, the course is very well structured. Today, that is on 9th of April, we are going at this point of time, we are going to start with drugs for glaucoma. We have been doing this for 6th of April, since 6th of April, and 6 episodes have been completed. So if you have missed any of these episodes, go and watch them after this session. So let's start. First question on your screen. Simple question to begin with. Match the drug in column A with its mechanism of action in column B. So I'll give you 10 to 15 questions in this half an hour, and believe me, if you are able to solve these MCQs and revise them and remember them, you will not find even a single MCQ of the anti-glaucoma drug getting wrong in the upcoming examination. So first question, match the drug with its mechanism of action. Very, very simple. Whenever you have such a question, try to find out the option that you think is the simplest and you are most confident about that. So I think latanoprost, which is a prostaglandin analog, it increases uveoscleral outflow. That is known to every student. So 2 goes with B. Similarly, betaxolol, which is a beta blocker. Beta blockers decrease aqueous production. So 3 will go with D. 3 will go with D. Netarsudil, very, very important. Netarsudil is a new drug, topical eye drop for treatment of open angle glaucoma. It is a Rho kinase. Please remember, new drug, Rho kinase inhibitor. And what does it do? Like miotics, like pilocarpine, it also increases the trabecular outflow. So 4 goes with C, and obviously then we are left with brimonidine. So I'm thinking of marking it as A, but then I see A is carbonic anhydrase inhibitor. So one cannot be A. This is wrong. This is not a carbonic anhydrase inhibitor. This is an alpha-2 agonist. Alpha-2 agonist, and they also decrease aqueous humor production. So one will also go with D. One will also go with D. So that is the answer. Avinash has also joined. Welcome, Avinash. So Avinash is saying D, B, D, C. That is what I'm looking for, and that is the answer, D, B, D, C. So please remember and match the columns. It is not essential that all the columns will be matched to all the columns on the right side. So you have to be very, very careful, vigilant, and please understand that on an average, this type of question will take roughly around 1 minute to solve. So 45 seconds at least you give to such questions. Do not solve them in hurry. Check, write the answers, then evaluate and find the correct option. Okay, so that is correct, Avinash. Option is D. Next question. This was a simple one. Now as we move ahead, we will discuss everything about anti-glaucoma drugs. Which drugs reduces IOP by increasing both trabecular as well as the uveoscleral outflow? So let me know. Yes, which drug can act on both trabecular as well as the uveoscleral outflow? Which is that drug? Which is that drug that increases both trabecular? So normally we know trabecular is increased by miotics, and also I have told you a new drug, netarsudil. The increased trabecular. Uveoscleral outflow is generally increased by prostaglandin analogues. Now which is the drug which can increase both? Option number C says Avinash, and option number C is the correct, latanoprostene bunod. So what is this drug? This is a combination of latanoprost plus bunod, which releases nitric oxide. So that is what is this latanoprostene bunod. As you can see, NO is there in the bunod spelling. So this is latanoprost. Latanoprost will increase the uveoscleral outflow, and nitric oxide, when it is released, it also increases the trabecular outflow. So this is again a new drug, latanoprostene bunod, which will increase both trabecular as well as the uveoscleral outflow. That is the best answer. If that is not given, Fatima, if latanoprostene bunod is not given, then we may think of latanoprost as the secondary answer, because some books say that it increases trabecular also, although that is not widely accepted. But if latanoprostene bunod was not mentioned, then Fatima, probably your answer could be considered. But the best is latanoprostene bunod. Please remember, latanoprost plus bunod, which releases nitric oxide. Okay, so please remember, two new drugs, both are used as eye drops and both are used in treatment of open angle glaucoma. The netarsudil, Rho kinase inhibitor, increases trabecular. Latanoprostene bunod, latanoprost plus nitric oxide releasing substance. So welcome, Fatima. Prostaglandin analog. This is a very, very important question, both clinically as well as in theory. Prostaglandin F2 alpha analogues are considered first line drugs for open angle glaucoma. And this is a true statement. They are the best drug. Select the reasons for their preference. So why these drugs are first line or best drug to start the treatment of open angle glaucoma? You have to select the reasons for that. First statement says long acting and can be given OD. This, please remember, is a true statement. Mostly all prostaglandin analogues are given once daily at night. All of them are given once daily at night and they provide 24-hour IOP reduction. Okay, so they are given once daily and long acting. So this improves patients' compliance. So that is a good factor and one of the reasons why they are first line. Low incidences of systemic side effect. Now this word needs to be emphasized. Prostaglandin analogues have side effect but not systemic. That means they might have ocular. We will discuss in eye they may cause problems or side effects, but they have low incidences of systemic side effects. That means when you put the eye drops, they will not affect heart or lung or GIT or bladder or CNS to any great extent. Okay, to any great extent, they do not have systemic side effects. So this is true. This is true. High efficacy in lowering IUP. This is absolutely correct. They are the most efficacious IUP lowering drugs. Approximately 25% reduction in IOP from the baseline is seen with these drugs. No ocular side effect. That is false. There is no drug in glaucoma that does not produce side effect in eye. So they have ocular side effects as we will discuss later on. So no ocular side effect is a false statement. So why prostaglandin analogues are first line drugs? Because they are highly effective. They cause less systemic problems and they have good compliance because they are long acting and given once daily. So patient needs to take less frequent dosing. So 1, 2, 3 and true, and therefore option number A is the answer. Option number A is the answer. So Avinash, A is correct and Kaushik is also joined. He also says A and that is the correct answer. Okay, so prostaglandin analogues. Next question. Now we come to side effects of prostaglandin analogues. So you see, prostaglandin analogues, I have told you, they cause less or very little systemic problems, but they have some what we call as ocular problems. So what are those ocular side effects? You have to again select multiple latest pattern as we have been discussing throughout this revision series. Cystoid macular edema, lengthening of eyelashes, uveitis or keratitis, heterochromia iridis. Okay. So now first of all, let's see. Prostaglandin analogues do cause iris pigmentation. There is a brown to blackish iris pigmentation. So if the patient is putting the eye drop only, let's say in one of the eye, then this iris can become slightly darker or brownish in color, while the normal eye remains black, which is the normal color. So two iris can differ in color. So that is why the term hetero means different, chromia is color, iridis. The two eyes become of different color. Prostaglandins. See, you see, these are prostaglandins. So they will cause side effects of inflammatory nature. So they can worsen uveitis, keratitis, these kind of inflammatory problems in eye, they can worsen. So this is a known side effect. Lengthening of eyelashes. Lengthening of eyelashes is another side effect of prostaglandin analogues. So eyelashes, the eye which is receiving the prostaglandin eye drops, the eyelashes of this eye can increase or lengthen. So that is also an ocular side effect, lengthening of eyelashes, and they can cause macular edema. That is also a known side effect of prostaglandin analog. So all the four are side effect and therefore option number D. Yes, Fatima, Avinash, everybody is correct. So how we remember? We remember the side effects by the mnemonic CLIP. Simple mnemonic, CLIP. CLIP is the mnemonic. What does CLIP stand for? C stands for cystoid macular edema, as you can see. L stands for lengthening of eyelashes. I stands for inflammatory conditions of eye like uveitis, iriditis, and P stands for pigmentation of eyes. So prostaglandins have these ocular side effects, can be remembered by simple mnemonic CLIP. Okay, CLIP. Cystoid macular edema, lengthening of eyelashes, inflammatory conditions of eye, and pigmentation of iris. So this is a very useful mnemonic to remember the side effects of prostaglandin analogues. So option D is the correct answer here. Next question. Now, we have discussed prostaglandin mechanism, we have discussed why they are first line, and we have discussed what are their ocular side effects. So, prostaglandins, which are the most important drug for open angle glaucoma, are covered. Now, we go to the second most important drug, that is beta blocker. So, beta blocker which should be avoided in glaucoma are, tell me now. So, first point that we have to understand, why would we avoid beta blocker in glaucoma? So which property makes beta blocker avoidable in glaucoma? So suppose this is eye and you are putting the eye drop, some eye drop of a beta blocker in eye. Now please remember those beta blockers which have what we call as the local anesthetic action. Local anesthetic, because the drug is capable of blocking sodium channels. So it causes local anesthesia in eye, because it can block sodium channel, and this property is also known as membrane stabilizing action. So any beta blocker which has sodium channel blocking property will cause local anesthesia, and if you put eye drop of such a beta blocker in eye, it will cause corneal anesthesia. It will cause corneal anesthesia, cornea will be anesthetized, and that would increase the risk of corneal injury, because blink response will be absent, and foreign particles, dust particles, insects, your own hands, they can damage cornea. Patient will be unaware because cornea is anesthetized. So we are looking for any beta blocker which has local anesthetic property, and that beta blocker will be avoided in glaucoma. Understood? Why beta blockers are to be avoided? Because some of the beta blockers can cause local anesthetic property. Now, which are those beta blockers? They are remembered by the mnemonic C-LAMP. Beta blockers with local anesthetic or sodium channel blocking property are remembered by the mnemonic C-LAMP, or you can also call it CLAMP. Anyhow, you won't remember. There are 2P, so quickly write. Maximum of this action is seen in propranolol. So we will not put propranolol in eye as eye drop. So propranolol is out. Next P is pindolol. Pindolol also has this property. It will also not be used in glaucoma or as eye drop. M metoprolol. A is AC butalol. L is labetalol, and C is carvedilol. So all these beta blockers, which can be remembered by the simple mnemonic CLAMP, they have local anesthetic property and they will cause corneal injury or increase the risk of corneal injury. So they are not to be put as eye drop in glaucoma. So we are looking at carvedilol, labetalol, pindolol, propranolol. None of them will be used in glaucoma. So again, option is D. Option is D. So clear? Nobody attempted this particular question. So is it clear now? Which beta blockers are to be avoided in glaucoma? Any beta blocker with local anesthetic property will be avoided in glaucoma. Okay, it will not be put as eye drop in eye. Clear? And in glaucoma, we are using beta blockers as eye drops, not systemically. So these beta blockers will be avoided. Remember the mnemonic CLAMP. Okay. So beta blockers to be used in glaucoma should not have local anesthetic action. Next question. I hope everybody has understood this question. If there is any problem, let me know and I'll repeat. Okay. So bit of yes or no from your side would let me know if you have understood or not. Okay. As I always say, The whole purpose of having YouTube live session is to be more interactive so that we come to know which points are clear to you and which are not. So please request all of you participate, provide your comments. Continuous flow of comments should be there. Beta blocker, now we have least likely to cause corneal damage. Totally opposite question to the previous one. So beta blockers, if you look at beta blockers and their ocular side effect, then dry eye, you can remember it with A, B, C, D. Ocular side effect of beta blocker. So there is dry eye, there is corneal damage, or we can say punctate keratitis, then there is burning sensation of eye, burning in eye, and then there is this allergic conjunctivitis. So A B C D, and D will also help you remember duct block. And I hope with respect to eye, you can remember which duct we are talking. We are talking of nasolacrimal duct. Nasolacrimal duct block is also seen with beta blocker. So again, simple mnemonic A, B, C, D. Now the question is asking which beta blocker is least likely to cause corneal damage. So what corneal damage is seen with beta blocker? As I told, punctate keratitis. Punctate keratitis is commonly seen with beta blocker, corneal damage. So these are the 4 beta blockers, 3 timolol, betaxolol, cartiolol. There is one more beta blocker, propranolol is not used in eye, as I have told you. There is one more beta blocker used as eye drop, that is known as levobunolol. So the cartiolol, timolol, betaxolol, levobunolol, these are the important beta blockers used as eye drop in glaucoma. Out of this, which will cause least this punctate keratitis or corneal damage? Answer is cartiolol. Remember, cartiolol has the least risk of causing corneal damage amongst beta block. So this is something that you want to remember. Beta blockers can cause punctate, superficial punctate keratitis, corneal damage. Cartiolol is least likely to cause this corneal damage. So that is a one-liner memory-based question that you have to remember. A follow-up question to the previous question. Now the question is asking most common location of nasolacrimal duct block by anti-glaucoma drugs. So now they are not specified which drug, but nasolacrimal duct can be blocked by some anti-glaucoma drug. First of all, we have to know which anti-glaucoma drug cause nasolacrimal duct block. So please remember, beta blockers are the most common cause among anti-glaucoma drug to cause nasolacrimal duct block. If they are not given in the option, then the next class of drugs is miotics. They can also cause. The question is asking most common location. So most common location is from where the duct starts in eye. So punctum, if given in the option, would be the best. If punctum is not given, then superior canaliculi. Superior canaliculi is the next most common site of nasolacrimal duct block. So we are not given punctum, opening of duct, and nose is given, not in eye. So that is not. Superior canaliculi is given, and out of the options, this is the best answer. This is the best answer. Okay. Yes, Kaushik and Avinash, absolutely correct. That is the best answer. Most common location of nasolacrimal duct block is the punctum followed by superior canaliculi. Okay. So again, remember, this is very commonly asked. In fact, it has been asked twice already. Next question. Which anti-glaucoma drug can cause electrolyte disturbances like metabolic acidosis and hypokalemia? Very important question. Very important question. Anti-glaucoma drug causing Electrolyte disturbances. These are systemic side effects. Electrolyte disturbances like metabolic acidosis and hypokalemia. So these problems, metabolic acidosis, hypokalemia, this is very, very important. Which type of drug are you looking at? Which type of drug, which class of drug are you looking at? We are looking at carbonic anhydrase inhibitor. So carbonic anhydrase inhibitor have these problems of causing metabolic acidosis. So carbonic anhydrase inhibitor, the maximum is caused by acetazolamide. Now please remember here, acetazolamide is given by oral or IV. It is not eye drop, it is not topical. So this will cause maximum of these systemic side effects. If this is not given, if acetazolamide suppose is not given, then look for the topical carbonic anhydrase inhibitor like dorzolamide also. So dorzolamide is given as eye drop, but it can also undergo some systemic absorption and can lead to metabolic side effects. So please remember, due to carbonic anhydrase inhibitor, number 1, metabolic acidosis. Secondly, loss of potassium, hypokalemia. Now, hypokalemia frequently would cause, please remember, frequently would cause a common side effect that is very commonly asked, that is paresthesia. So, if you are asked which anti-glaucoma drug causes paresthesia, tingling sensation, that is also carbonic anhydrase inhibitor, and paresthesia is due to hypokalemia. And third, these drugs can also cause renal stone. Renal stones are also possible because of carbonic anhydrase inhibition. So these are the systemic side effects that are likely to occur with acetazolamide carbonic anhydrase inhibitor. So Dr. G.S. Mishra is correct, Avinash, Fatima, Kaushik, everybody is correct. So renal stone also, please remember, renal stone these drugs can cause. Now we have another anti-glaucoma drug side effect asked. In glaucoma you will find only 2 type of questions are asked. One is either the mechanism of action, which we covered in the initial 2 question, and rest all is side effects. So which anti-glaucoma drug causes maximum? The question is asking maximum allergic blepharoconjunctivitis. So allergic blepharoconjunctivitis is caused by many anti-glaucoma eye drops. Alpha-2 agonist cause it. Even the carbonic anhydrase inhibitors like dorzolamide cause it. Even beta blockers cause it. But which one causes maximum ocular allergy or allergic blepharoconjunctivitis? Tell me this answer. Maximum allergic blepharoconjunctivitis. Is it timolol? Is it apraclonidine? Is it latanoprost? And is it acetazolamide? Which one causes maximum allergic blepharoconjunctivitis? Avinash says timolol, that is option A. What about Dr. G.S. Mishra? What about Kaushik? What about Fatima? What do you say? Everybody, you just have to type A, B, C, D. That is all. Quickly, what is your answer? What do you think is the drug responsible for maximum allergic blepharoconjunctivitis? Okay, the answer is apraclonidine. Please remember, alpha-2 agonists such as apraclonidine cause maximum allergic blepharoconjunctivitis. Alpha-2 agonist as a class and apraclonidine within that class. Okay, so apraclonidine causes it more than brimonidine. Okay, so both can cause, but maximum is caused by apraclonidine, and as a class alpha-2 agonist. Alpha-2 agonist. Yes, so Sayanta, you are correct. That is the answer. And which one causes minimum allergic? That is latanoprost or prostaglandin analogues cause minimum. Apraclonidine will cause maximum. This is very, very important. Maximum NLD blockade, beta blocker. Maximum allergic blepharoconjunctivitis, alpha-2 agonist. Okay. Maximum metabolic or acidosis, carbonic anhydrase inhibitor. Now we come to which anti-glaucoma. This is a very, very frequently asked question and very, very relevant question. Which anti-glaucoma medication is unsafe in infants, or you can also say children? Children less than 8 years, which anti-glaucoma medication should not be given? Should not be given. Ria, I think we have discussed the answer to previous question was apraclonidine. Unsafe in children. So there is an anti-glaucoma medication that can cause CNS depression. This can result in sedation. This can even result in apnea. In sleep apnea can also occur. Apneal episodes or apnea episodes can also occur in children. And which is that drug? Which is that drug? That drug is brimonidine. Brimonidine. So brimonidine is an anti-glaucoma drug. It has high blood-brain barrier penetration. It can cause sedation and apnea in infants. So do not give brimonidine in children and in infants. Clear? Brimonidine. High blood-brain barrier penetration. So apraclonidine and brimonidine. Both are alpha-2 agonist. But brimonidine, as I told, high blood-brain barrier penetration, and apraclonidine, poor blood-brain barrier penetration. Okay? So brimonidine causes. There are some more points about brimonidine which we are going to follow. So which one is unsafe? Brimonidine. Since you are telling me which one is unsafe, it is a logical question to ask which anti-glaucoma medication is safe in children. You see, the logical question is, if we know unsafe, we should know which one is safe. So which anti-glaucoma medication is safe in children? So Dr. G.S. Mishra, you are correct. Fatima, Sayantan, everybody is correct. Now tell me which one is safe in children. Unsafe हो गया तो safe भी बता दीजिए फिर. Safe in children. तो बच्चों में कौन सी anti-glaucoma medication we would prefer? Quickly. Which one we will not prefer is brimonidine. The same options come. Now, which one is safe in children? Dorzolamide or carbonic anhydrase are believed to be safest in children. Okay. So, carbonic anhydrase inhibitors are believed to be safe in children, and they are the ones which are preferred in children. Okay. So, this is just another MCQ that you should know, carbonic anhydrase inhibitors. Okay. So, that is the answer. Now, if you are talking about safety, then I would definitely ask or want to know which anti-glaucoma medication is safe in pregnancy. Safety in children हो गया तो safety in pregnancy भी बता दीजिए. So you see, this is a logical flow of the question and how we should ask or tend to gather information. बच्चों में कौन सी safe नहीं है? Logical subsequent question is कौन सी safe है? और safe है तो pregnancy में safety हमेशा पूछी जाती है. So tell me now which is safe in pregnancy. And now you see you will understand some important thing now. Okay, clinically relevance. So please see, pregnancy में latanoprost, one by one you see, latanoprost is a prostaglandin, F2. And you might recall कि prostaglandin F are uterine stimulant. तो डायनोप्रोस्ट, कार्बोप्रोस्ट, इस तरह की ड्रग्स हमने पढ़ी है, यूट्राइन स्टिमुलेंट. प्रोस्टाग्लैंडिन्स है, दे इंक्रीज यूट्राइन कंट्रैक्शन. तो ये तो प्रेगनेंसी में सेफ नहीं है. विच वन इज सेफ? तो देखिए, फर्स्ट ट्राइमेस्टर वाइज अगर मैं आपको बताऊं, फर्स्ट द मैक्सिमम सेफ्टी इज बिलीव टू बी ब्रिमोनिडी. क्लियर? So that is the answer. The maximum safety lies with brimonidine in pregnancy. Okay, brimonidine. So Avinash, that is correct. B, Dr. G.S. Mishra, latanoprost, prostaglandins are uterine contract, uterine stimulant, तो वो आप अवॉइड करें. तो अब देखिए ब्रिमोनिडीन फर्स्ट ट्राइमेस्टर में तो यू विल गिव ओनली एंड ओनली ब्रिमोनिडीन. ये FDA की कैटेगरी बी ड्रग है प्रेगनेंसी. कैटेगरी बी A is considered safest in pregnancy, कैटेगरी बी उससे नीचे आती है तो it is quite safe. हाँ, तो ब्रिमोनिडीन you will give in first trimester. Second and third, you can also give beta blocker or carbonic anhydrase inhibitor along with brimonidine. You can give that also if brimonidine is not available. Now is the real clinically relevant question. You see, now we have near term, okay, or post delivery. So near term or post delivery, what drug will never be given? Never you will give. Which drug? Can you tell me? Near term. We are into last few weeks of pregnancy or just after delivery. Which drug, anti-glaucoma drug, you would avoid in pregnancy, in this pregnant or just postpartum lady? I have already told you the answer. Can you clinically make any correlation between the last 2-3 questions? Near term or post just after delivery. Which drug you will not give? The reason I have already told you. Can you tell me this particular thing? बताइए. So please remember, you will never give brimonidine. Why? Because थोड़ी देर पहले I told you it can cause apnea in infant. तो पोस्ट डिलीवरी बच्चा जस्ट है, लेक्टेटिंग मदर है या नियर टर्म है, द ड्रग कैन पास थ्रू प्लेसेंटा और थ्रू दी milk. So and if passes, it will cause apnea in infant. So brimonidine is safe. It is not teratogenic. Okay, but once organogenesis is over, तब teratogeny वाला point हट जाएगा. And near term or just after delivery, there is risk of brimonidine passing to the infant via the placenta or via the milk. So and it can cause apnea in infant. So brimonidine, which is safe in pregnancy, drug of choice in first trimester, should never be given near term or just after delivery. So clear? प्रोस्टाग्लैंडिन्स तो यूट्राइन स्टिमुलेंट है, आपको पता है. प्रोस्टाग्लैंडिन अल्फा आपने पढ़े हैं, डायनोप्रोस्ट, कार्बोप्रोस्टॉन, डायनोप्रोस्टॉन, वो तो हम सर्वाइकल राइटनिंग और उन सब के चीजों के लिए यूज करते हैं. तो दे आर नेवर गिवन इन प्रेगनेंसी. ओके, पीडीए वगैरह क्लोजर नहीं करते हैं प्रोस्टाग्लैंडिन्स की. पीडीए डक्टस ओपन, पीडीए क्लोज अविनाश करते हैं. डक्टस का यू आर सेइंग विल डिले PDA closure or will delay ductus closure, you should say. Yes, prostaglandins. तो prostaglandin तो नहीं देने. तो clear? Pregnancy में safe brimonidine है, no teratogenicity, but do not give near term or just after delivery. Now we come to this question. Again, one liner. Lid retraction is caused by lid retraction. जल्दी बताइए. Lid retraction, upper eyelid retraction, Muller muscle. There is a muscle in upper eyelid, Muller muscle. अपर आईलिड में एक मसल है, मुलर मसल, ऑल्सो नोन एज सुपीरियर टार्सल मसल. दिस मसल कैन बी स्टिमुलेटेड बाय which drug? Yes, the answer is apraclonidine. Apraclonidine will stimulate and cause lid retraction. Okay, so which drug will cause it more? Apraclonidine will cause it much more than brimonidine. So if apraclonidine is not given, then you go for brimonidine. Okay, apraclonidine not given, then you go for brimonidine, but best is apraclonidine. And this property can be used, please remember, for treatment of ptosis. And ptosis should remind you of Horner's syndrome. So in Horner's syndrome, there is ptosis, drooping of eyelid, and which drug will cause retraction or upward movement of that eyelid? Apraclonidine. Okay, apraclonidine. Next, very important, and this will clarify alpha 2 agonist for you. The drug for control of post-operative, we have done, suppose, iridotomy. Suppose we have done capsulotomy. Okay, we have done some eye surgery, and just after eye surgery, there is sudden spike. Post surgery, there is sudden spike in IOP. IOP has suddenly gone up. Which drug you will give for short term? Patient otherwise is non-glaucoma patient, but suddenly post surgery the IOP has shot. You need to just control for short term. Which drug is used for control of this post-operative increase in intraocular pressure? Which drug will be given for this short term control of intraocular pressure? Tell me. Brimonidine, apraclonidine, latanoprost, none of the above. So you see, this is glaucoma is a very important topic, and that is why we need to have newer and newer question. Answer here is again apraclonidine. Apraclonidine. And that is, please understand, the main use of apraclonidine in glaucoma. The drug is used for short-term purposes only. Okay, so apraclonidine you will mainly find it is being mainly, I'm saying, for short-term, and if you want an alpha-2 agonist for long-term control, generally you will find brimonidine. So apraclonidine is given for short-term control of spike in intraocular pressure, like which happens post-operative. शॉर्ट टर्म के लिए apraclonidine, yes अविनाश, that is correct. So apraclonidine का ये main use है. Now we have anti-glaucoma drug in column A, and you have to match them with its contraindication in column B. So ये आपके all side effects I have told you. Now you need to decide which anti-glaucoma drug will be avoided in which type of patient. I hope you are finding the questions interesting. These are rapid revision MCQs. You solve these MCQs, you will find most of the questions in exam are likely to come from these kind of topics. Anti-glaucoma drug with its contraindication. So brimonidine we have discussed already, should be avoided in children because it can cause sedation and apnea in children. So one goes with A. Latanoprost, I have told you, prostaglandins increase the inflammation. So if patient has uveitis, if patient has any reason or history of macular edema, okay, if patient has history of uveitis or currently he is having uveitis, patient has macular edema, you will avoid prostaglandins. 2 goes with B, contraindicated. Betaxolol, beta blocker, although cardioselective, but beta blockers can worsen asthma, beta blockers can worsen heart block. Beta blocker should not be given post coronary artery disease patient. We do not give them. So 3 goes with C. 3 goes with C. Pilocarpine, which is a miotic, should be avoided. Miotics can cause retinal detachment. So 4th goes with D. So please remember, miotics cause retinal detachment. Okay, so they should be avoided in patient with history of retinal detachment. So I'm looking for A, B, C and D, and A, B, C and D, option number C. Option number C. So yes, Fatima, that is correct, and so is Avinash. Dr. Mishra is also quick and correct to answer. So the very important contraindicate. Okay, so please remember these contraindications. One more contraindications I will write: acetazolamide. This anti-glaucoma drug or carbonic anhydrase inhibitor should be avoided, contraindicated in patients with history of renal disease, patient has kidney disease, do not give, and patients who have history of sulfa allergy. Patient with history of sulfa allergy also do not give acetazolamide. So these are the important contraindications or conditions where respective anti-glaucoma drug should not be given. Out of which, please remember, children, patient with uveitis or macular edema, and obviously retinal detachment being an ocular condition, you should remember miotics are to be avoided. This is our last question for this session. Which drug can relieve pupillary block in acute glaucoma? Pupil block occurs in acute angle of glaucoma. Iris comes in contact with lens, that is known as pupillary block. Which drug can relieve this pupil block by causing, I will tell you, by causing constriction of the ciliary muscles. Which drug will relieve the pupillary block? This is fairly simple. Answer is miotics, and that is pilocarpine. Pilocarpine. So that is why if you are asked acute glaucoma, 3 questions can be asked in acute glaucoma. And what are those? Treatment of choice, TOC, is iridotomy. iridotomy, and nowadays YAG laser. We do not do it normal surgery, laser iridotomy, YAG laser. That is the treatment of choice. Fastest drug in acute angle closure glaucoma, mannitol, IV mannitol, and topical drug which will relieve the pupillary block, as we have discussed, pilocarpine. These are the kind of questions asked in acute angle closure glaucoma or attack of the narrow angle glaucoma. So pupillary block is relieved by miotics, not. So that is what we had in this episode. This episode of last minute revision MCQ. We have done drugs for glaucoma, completed drugs for glaucoma at 10 p.m. after 20 minutes. We will start with drugs for CHF. Drugs for CHF is our next topic, which will begin in just about 20 minutes. Again on your YouTube channel, favorite YouTube channel, Let's Crack NEET PG. And do not forget tomorrow, that is 10th of April, Saturday. 10th of April, Saturday, and this are free classes on Unacademy app, not on YouTube, on the Unacademy app. So if you have not downloaded the app, please download the app right away, and you will use the code Dr. Arpit Agarwal. When you will use this code, if you are the first time downloader of the app, you can unlock the free classes. And tomorrow we have 3 sessions, 9 to 10 a.m., 10:15 to 11:15, and 7 to 8 p.m., where I will discuss the latest pattern MCQ, clinical scenario based MCQ, and these are extremely important for the upcoming examination. Topic wise, we will cover the entire pharmacology and in a clinical scenario based MCQ. So please join me tomorrow at these time points. And if you have not downloaded the app, do it right away. Use the code Dr. Arpit to unlock the free classes. So that is all we had in this session. As I said, if you have not downloaded the app, do it right away from the Play Store. So thank you all for joining. I hope you enjoyed this particular session. You found the questions useful. Please provide your feedback in the comment section, and please do not forget to join me at 10 p.m. for another episode of the last minute revision MCQ. Thank you all for joining, and I